The gynecological clinical evaluation operates as a rigid chronological data filtering algorithm. It is the definitive framework for organizing raw patient data into a clinical structure. Before any data collection begins, the clinician must secure environmental prerequisites of patient trust and strict confidentiality. The evaluation is a bipartite system. It relies on two distinct phases: subjective history and the objective physical examination. Subjective history and objective exam data converge to form a clinical diagnosis. The patient's reported symptoms actively dictate which physical tests the clinician prioritizes. From the first input, the subjective history branches into targeted hypotheses, narrowing the investigation scope before the physical exam begins. Mastering this protocol requires a precise understanding of its chronological dependencies. Each step in the sequence relies on the specific data extracted in the previous phase. Adhering to this sequential algorithm allows for the discovery of subtle pathologies that a less structured, non-linear approach might overlook. The first phase of the algorithm captures demographic and baseline general data. Age and geographic residence provide the initial epidemiological context for the case. The chief complaint is recorded using the patient's own brief expressions, preserving the original description before it is filtered into medical terminology. Complaints such as pelvic pain or abnormal bleeding are mapped temporally. The clinician charts the cyclicity, the quantity of blood loss, and the exact timing of symptoms relative to the menstrual cycle. This fractional notation is the clinical standard for charting cycles. The numerator represents total cycle length, while the denominator tracks the duration of menses. These numerical configurations allow rapid visual parsing. Shifts immediately signal conditions like polymenorrhea. The obstetric history details past parities, the occurrence of spontaneous abortions, and the chronological timeline of all previous pregnancies. It is also essential to record the results and date of the last Pap test, alongside the patient's current contraceptive methods. Red flags in the medical and family history are prioritized, specifically the presence of hereditary breast or ovarian cancers, or underlying blood clotting disorders. This meticulously charted history focuses the diagnostic search on a narrow set of high-probability conditions, providing specific parameters for the physical examination. Moving to the objective examination, the evaluation begins with systemic signs far outside the pelvic cavity. After recording baseline vitals, the clinician monitors blood pressure. In advanced pregnancy, this requires side-lying positioning to prevent compression of the inferior vena cava. The clinician searches for distal indicators of disease, such as checking the conjunctivae for signs of anemia or observing facial and body hair distribution for evidence of endocrine disorders. The breast examination begins with the patient seated, hands behind the head. This position allows visual inspection of symmetry and superficial skin changes. Palpation follows a physical sequence through all four quadrants of the breast, concluding with a check of the axillary lymph nodes. The abdominal examination follows the standard clinical progression: inspection, palpation, percussion, and auscultation. During palpation, the clinician specifically targets signs of organomegaly or the presence of palpable intra-abdominal masses. Percussion is used to identify shifting dullness, the primary indicator of ascites, or fluid accumulation in the abdominal cavity. These systemic findings provide critical context. Markers like abnormal hair distribution or abdominal fluid often point directly toward primary ovarian or uterine pathologies. The pelvic exam requires the patient in the lithotomy position on a specialized gynecological bed, with a confirmed empty bladder to ensure accurate palpation. This diagram shows the anatomical topography of the external genitalia. The clinician inspects the vulva, perineum, and clitoris for inflammatory changes or growths. They then examine the urethromeatus, applying light pressure to check for pathological discharge. To palpate the Bartholin glands, the clinician places the thumb on the posterior labia majora and the index finger at the vaginal introitus, checking for swelling or tenderness. The clinician then utilizes the Valsalva maneuver. Asking the patient to bear down or cough allows the clinician to visually identify cystoceles, rectoceles, uterine prolapse, or stress urinary incontinence. This external inspection maps the superficial boundaries of potential infection or structural failure before the exam moves into the internal reproductive tract. In the pelvic algorithm, the speculum inspection must always precede bimanual palpation. This ensures the clinician collects cervical cytology and microbiological samples from an uncontaminated field before the introduction of lubricants or manual manipulation. With the cervix exposed, the clinician assesses the tissue for ulcerations, signs of trauma, or abnormal discharge. The inspection identifies specific anomalies like Nabothian cysts or inflammatory changes that may resemble neoplasia. 2 distinct cytological samples are then taken from the ectocervix and the endocervix for the Pap test. This sequence is dictated by the need for cellular integrity, transforming the examination from a general checkup into a precision data extraction event. Figure 2.4 illustrates the bimanual exam. The internal fingers and external hand apply counterpressure to determine the size, position, and mobility of the uterus. The clinician simultaneously assesses the cervix for dilation and excitation pain. The hands then shift laterally to palpate the adnexa. In a healthy patient, the fallopian tubes and ovaries are typically not palpable unless the individual is exceptionally thin. If an adnexal mass is identified, it is categorized by size, consistency, and whether it is fixed to or mobile within the surrounding tissues. The bimanual exam creates a 3-dimensional structural map of the internal anatomy, completing the physical diagnostic sequence. By the end of the sequence, the patient history has framed the anatomical findings discovered during the physical examination. This process frequently reveals silent pathologies, such as a fixed uterus caused by adhesions, that the subjective history alone could not detect. The entire evaluation culminates in the diagnostic hypothesis. This hypothesis branches into 2 final tools: transvaginal ultrasound and specialized lab profiles. It provides specific parameters for the ultrasound to verify structural anomalies and dictates which biochemical markers are requested, ensuring efficient diagnosis. Clinical mastery depends on the flawless execution of this sequential data filtering algorithm. It is this process that transforms anatomical observations into precise, evidence-based interventions.